Greetings from Kuala Lumpur, Malaysia. On behalf of the President of the Malaysian Society of Gastroenterology and Hepatology, MSGH, Professor Raja Effendi Raja Ali, I wish all of you a warm welcome to today's webinar. Current perspectives on COVID-19, GI, and liver manifestations. This webinar is brought to you by INEDSYS in collaboration with Delhi Liver Foundation and MSGH. I'm Dr. Chan Wah Keong, a professor and consultant gastroenterologist and hepatologist at the University of Malaya Medical Center, UMMC, here in Kuala Lumpur, and committee member of the MSGH. Joining me to moderate this webinar today is my colleague, Dr. Ruvina Bhavani Rajaram, consultant gastroenterologist and hepatologist here at UMMC. We are really fortunate to have three excellent speakers with us today. I really look forward to their talks and to learning from them. Without further ado, I'll pass the microphone to Dr. Ruvina to introduce to you the first speaker.
Thank you, Wah Keong. A very good day to all the speakers and participants, and thank you once again for being here. We are pleased to welcome our first speaker, Professor Dr. Anil Arora, who is the Chairman of Institute of Liver, Gastroenterology and Pancreatobiliary Services at Sir Gangaram Hospital in New Delhi, India. He is a well-accomplished academician with over 90 publications in index journals and is well known for his major contribution in relation to the role of achlorhydria in prevention and controlling bleeding peptic ulcer, as well as in the diagnosis and management of Budd-Chiari syndrome. His area of expertise includes advanced therapeutic endoscopy and viral hepatitis. And today, he will be giving a talk on pathobiology of COVID-19 and its clinical implications. Dr. Anil, you may begin now.
Okay. Thank you, Professor Ruvina. It is a pleasure to see you all. I'll just start sharing my screen. Good evening, everybody. The topic of my presentation is pathobiology of the COVID-19. Why should we know as gastroenterology and hepatology the basic virology, and does it impact the clinical manifestation of the disease? I think it is extremely important to understand what this virus is, how does it enter the body, why is it causing such a big epidemic problem throughout the world. In fact, coronaviruses are of two types. You have a common coronavirus like influenza, common cold, which usually affect the upper respiratory tract and nothing happens to us. You just take any anti-inflammatory or antihistaminic agent and the disease settles down. You do not even have to take time off your office. But then there are different type of coronavirus which primarily affect the animals, and at times they tend to switch their loyalty and they come into the human beings. And this shift over from one species of animals to the human beings results in catastrophic pandemics, of which two have recently been well documented in the human beings over the last 2 decades. Out of the 5,000 species of the coronaviruses which are known, we recently have been affected by 2 of these dangerous coronaviruses which are presented as pandemic. The first pandemic was reported in 2002 from China, in which 8,000 patients were reported with a mortality of in about 774 patients. Second episode of the dangerous coronavirus, which was primarily affecting the lower respiratory tract, was called MERS-CoV infection, that is Middle East Respiratory Distress Syndrome, which originated in the Middle East with intermediate host as Doom's camels, which had presented with the second type of problem. And today we are concerned about this new phenomena of a third coronavirus, which has originated in this city, in this port city of Wuhan, in which there used to be and there are still number of live animal markets in which there have been mixing up of large number of the animal meat products. So somewhere down the lane, there was a changeover of the virus from the animal, shift over of the virus from the animal to the human beings via a possible intermediate host called pangolin. So this was detected, and finally the Chinese authorities, without knowing as to what the virus is, they knew that this is a coronavirus, so they named it as a novel coronavirus. With passage of time, more and more countries got infected, and the disease had become pandemic. And by 11th March, WHO had no option but to declare this increasing menace of the coronavirus affecting the lower respiratory tract infection to be a pandemic affecting almost 184 countries by now. And see the basic difference between the first two types of coronavirus, that is SARS-CoV and MERS-CoV, which occurred in 2002 and 2010. So every decade you are having a new virus infection, and it's having more and more problem. By today, there have been about 4 million cases of coronavirus infection all over the world, with 2,075,000 mortalities. The basic difference between the coronavirus infection, that is SARS-CoV-2, which is the causative agent of the COVID-19, is that it has a high infectivity, but luckily for us, luckily for our patient, the mortality is much less than with SARS-CoV infection in 2002, and 30% mortality, which was documented in the Ebola virus, in the MERS-CoV-2 infection, which was documented in 2002 from the Middle East. The basic difference between the first COVID-1 SARS infection and the present SARS-CoV-2 or the COVID-19 infection was that we knew the intermediate host to be the civet cat in the first SARS-CoV infection. So it was easy to catch hold of this intermediate host. You cull those animals and you were able to break the chain. Unfortunately, in the present episode of the COVID-19, we do not know the intermediate host of the COVID-2, and hence the disease is still spreading like wildfire. Second difference between the two was that most of the patients who had the disease, they were symptomatic, they could be hospitalized, you could implement the barrier nursing, and hence the widespread community infection could be prevented. Unlike in COVID-19, where a significant proportion of the patients may have asymptomatic or pre-symptomatic disease, since you are not able to catch hold of them, so it is spreading like anything in the whole community. This is the basic structure of this RNA virus, which is a single-stranded RNA virus, which has a typical envelope protein, which is covering the nucleocapsid. And all these coronaviruses have associated spike-like projection, and hence this virus is known as coronavirus because it looks like the crown. And this is the basic structure of the spike, which is so important in letting the virus attach to the host cell and gain entry into the host. As the coronavirus with its spike proteins tends to enter the cell, it encounters and it uses the facility of this receptor called angiotensin convertase enzyme 2 type 2 receptor to attach to the host cell and then finally get invaginated and endocystized into the cell. Prior to that, it might require the need of a transmembrane serine protease enzyme called TMPRSS2. So once the virus attaches to the ACE2 receptor, there is an activation of this protease, serine protease enzyme, leading to invagination of these two complexes come together. That leads to virus getting attached and endocytized into the cell. And once it is into the cell, then it is quickly endocystized into the cytoplasmic component of the host cell. Now, just to tell you something new which has recently emerged as to what is the role of ACE2 receptors. Now, there are two types of ACE receptors, ACE1 and ACE2. Most of the lung parenchyma, especially the type 2 type of alveolocytes, they have ACE2 receptor. And once you have the virus which attaches this to this ACE2 receptor, the virus, this ACE2 receptors get neutralized, it gets downregulated. Normally, there is a balance between ACE1 and ACE2. As the virus is trying to degrade or downgrade this ACE2 receptor, there is a corresponding increase in the ACE1. So this rise in ACE1 leads to shift over of the angiotensin 1 into a potent vasoconstrictor called angiotensin 2, which has recently been implicated in the exacerbation of the pulmonary vascular injury, which is an important part of the ARDS component in patients who have fatal infection because of the COVID-19. As the virus enters into the cell, it fuses with a acidic structure called lysosome. which quickly tries to disintegrate this virus, and the various components of the viral protein, they are put in a segregated manner into the cytoplasm. And the already ready pool of the messenger RNA and the ribosome, endoplasmic reticulum, and Golgi apparatus, as if is waiting for the virus to come and let it proliferate. Something happens down the lane that the naked RNA, which is a positive stranded RNA, rapidly keeps using the resources of the intracytoplasmic machinery and keeps on producing more and more virions, leading to the production of the large amount of the virus, which then has to be extruded to affect the other cells which are in the vicinity of the parent cell. So this is what happens. The virus is entering the cell. You have a positive stranded RNA. It first of all, it produces another enzyme called RNA polymerase, which produces a negative strand of HCV RNA, a negative strand of the COVID virus RNA, which again produces a positive strand. So a combination of positive and negative strand leads to replication of the virus, and then these both positive and negative strands get translated onto the ribosome, producing all the components of the virus in the form of nucleocapsid, envelope protein, and protein, spike protein. And finally, the new virions are extruded out and they are ready to infect the other parts. So why is it that our body system is so weak that it's not able to get the virus out? And why is it that we are getting affected and with significant mortality, especially in the developed world like US? Normally, if the virus enters into the body cells, it is disintegrated into various components, and these various components like RNA or double-stranded DNA of the virus or other structural component, they are picked up by the intracytoplasmic and endosomal toll-like receptors. They recognize these viral particles or the virus components as the foreign agents. That leads to production of a substance called interferon, which diffuses into the surrounding cells, and through the attachment of the interferon receptor, it stimulates the production of interferon stimulated genes, which produces pro-inflammatory cytokines, and these cells get killed. So this is the normal way how invading microorganism like virus produces a defensive mechanism in the cytoplasm of the body, so that it produces a nearby antiviral state in the surrounding cell. In addition, you have innate immune response, and which is present, which will detect the virus. This is a typical macrophage which will detect the incoming virus by looking at the pathogen-associated molecular pattern of this virus, and it using both the cytoplasmic as well as the membrane-bound TLRs, it produces an innate response leading to inflammation and production of the antibody so that the virus is neutralized. That is what happens in a normal person. Let us see what is wrong with this virus. Why is it that the virus is able to evade the immune response and is going to create havoc? What happens with COVID-19 infection or SARS-CoV-2 infection is that once it is replicating within the host cell, it tends to drag a double membrane vesicle, stealing it from the endoplasmic reticulum and the Golgi apparatus, and keeps on multiplying within the double membrane vesicle. So virus keeps multiplying, and it is hiding itself from the intracytoplasmic toll-like receptors, which will identify this as a foreign agent. So in spite of hiding from the intracytoplasmic defenses, it keeps on multiplying within the cell, producing large amount of the virion. Not only that, once the virus is present in the body, it has 4 ways by which it can block the intracytoplasmic first line defense, that is the production of the type 1 interferon. It can prevent the fusion of the virus with the lysosome. It can prevent the stimulation of the IRF3 gene, which will produce interferon. It will prevent the recognition of the endocytoplasmic and endoribosomal TLRs for recognition of the DNA of the virus, double-stranded DNA. And also it prevents the auto loop re-entry of the interferon into the cell to produce an antiviral immunity. So at 4 places, this virus is trying to defy all the norms of the self-defense and keeps on multiplying at its own sweet pace. So we have lost the first line immune defense, that is type 1 interferon. Now, if we still want to save our body, we have to depend on an adaptive immunity. That adaptive immunity will require a cytotoxic T cells and antibody-mediated injury to the cell which is containing the virus. So this has to be robust to get rid of the virus if the first system fails. So this is what happens with COVID-19 infection, that it upregulates interleukin 6. This interleukin 6 or IL-6 leads to changeover from Th1 to Th2 type of response. That leads to reduced cytolysis. That means you are not able to generate CD8 type of response, and hence the cytotoxicity of the adaptive immune response fails. In addition, this interleukin 6 again reduces the apoptosis of the cell and also leads to increased expression of the PD-1 antibody. That means the virus is allowed to remain in the body without being detected by the CD8 cells. So you have a dual problem in COVID. It keeps on multiplying, hiding itself from the intracytoplasmic defenses, and it has a very poor response in terms of generation of the CD8 cells or the antibody-mediated response. So this is what is happening at the level of the lung, where the problem starts. Once you inhale the virus goes into the alveocyte. This is a alveocyte which has the incoming COVID virus infection. You have failed in terms of generation of the type 1 interferon. Large amount of the virus comes into the perialveolar tissue. That leads to stimulation of the pro-inflammatory cells like macrophages and neutrophils. And in addition, there is a suppression of response which will try to kill the virus. CD8 is down, B cells are down. So what is upregulated is the pro-inflammatory cells in the form of activated neutrophils and macrophages. That is what leads to excessive production of pro-inflammatory cytokines, leading to exaggerated immune response. So this is what is happening in COVID virus infection, that in a normal individual, once you have a virus entering into the cell, you have a type 1 interferon which stimulates the immune defenses and the virus gets under control. This is the common type of simple infection of the common cold which we get. In SARS-CoV-2 infection, there is a lack of initial delayed response, which leads to multiplication of the virus. And in the second phase, the exaggerated neutrophils and the monocytes, they produce an exaggerated and dysregulated immune response, trying to kill the cells which are harboring the virus, leading to exaggerated immune response and the ARDS. If there is no exaggeration of the immune response, one can go scot-free. So this is what is happening in a normal person. This is what happens in a patient with COVID-19 who is going to have high mortality. So there are 3 phases of infection in COVID virus infection. In the first phase, you are letting the virus go and multiply exorbitantly because you do not have good antiviral response in the form of generation of interferon. In the second phase, if the virus replication stops and your body does not react to it, most of us will have simple, mild or moderate disease. No treatment is needed. You can stay at home. But look at this 15% of the patients who will generate an exaggerated, dysregulated, hyper-stimulated immune response. These are the patients who are likely to go into ARDS, septicemia, and multi-organ failure, leading to mortality. So what kills the patients in COVID infection is the host immunity, not the cytopathogenicity related to the direct virus alone. So these are the 3 major presentations of the virus. You may be asymptomatic, you have mild disease or severe disease. Again, it will be determined by what type of immune response you generate in your own body. So this can then very well serve as the pathological basis for the therapy. Let's see how it helps. We know if we interfere with the entry blocker, this is the receptor which is important for the entry of the virus into the cell. So if we are able to block ACE2 receptor or transmembrane serine protease receptor, then maybe we may be able to prevent the infection of the virus into our host system. But then there is a problem with ACE2 receptor. I told you the difference between ACE2 and ACE1 is still we do not know whether the blockage of this is going to be beneficial or harmful to us. There is some suggestion that if you neutralize the cytoplasmic component of the ACE2, that means if you give soluble A2, maybe you will have some relief in the virus. Second is, can we prevent the activation of the co-stimulant molecule, that is TMPRSS2, that is transmembrane protein serine inhibitor. There is a drug which is available called camostat mesylate. If we block it, we may be able to prevent the entry of the virus into the cell. Similarly, as the virus enters into the cell, it keeps on multiplying, and Dr. Robert Gish is going to tell us whether the whether cessation of the multiplication or interference with the multiplication at this level may be able to prevent the ongoing replication of the virus. There is a drug called chloroquine, which has been recently into news as a wonder drug for treatment of COVID virus infection. It has two basic mechanisms of action. It decreases the attachment of the virus onto the cell. In addition, it interferes with the viral replication within the cell. So it has a dual mechanism. At the same time, chloroquine is also a known drug which is known to decrease the inflammatory component by down-regulating TNF-alpha and also decreasing the leukocyte adhesion molecule. For these two mechanisms, we have a drug which is possibly of some use in patients with COVID-19 infection. And Dr. Robert Gish is going to tell us how well it is going to be of use in our patients with COVID-19 infection. Finally, we have immune-targeted therapy. And the basis of this is, you see, as I showed you in my initial presentation, that the virus keeps multiplying at a very good pace in the initial phase. So this is the time when, after a few days of infection, the virus is multiplying at a very rapid pace, when the B cells are decreasing, T cells are decreasing, and the patient has lymphopenia. So if at this point of time you're able to catch hold of the infection, then you can treat the patient with IVIG to neutralize the body by opsonization and also using low molecular weight heparin. There is some role which Dr. Robert will be talking of, neutralizing the pro-inflammatory cytokines which are problem. And finally, once you have to develop a vaccine, you should understand that you have to identify the various components of the virus which will generate different type of response. We have to choose which particular component of the virus is going to generate the neutralizing one antibody, which can be used as an antigen to produce vaccine. And this is an elegant study from Singapore, which has clearly shown that the maximum concentration of the COVID-19 infection virus is present in the secretory goblet nasal mucosal cells. So if we have to use one route, the best route for vaccination will be a transnasal route. So to summarize, ladies and gentlemen, I've shown you pathogenically these are the different stages of the infection. In the first phase, you have high viral replication. In the second stage, there is a tug of war between the virus and inflammatory response. And finally, if the body loses the response to hyperexaggerated immune state, then you are down with ARDS. Depending on what stage of the patient you come in, you can choose your medical therapy which can be given. So to sum up, ladies and gentlemen, my final slide is that in patient with COVID infection, you start with the asymptomatic phase, and as the virus keeps on multiplying, you have high infectivity of the virus because of the rapid application in the pre-symptomatic phase. The pre-symptomatic phase with high viral replication occurs because of the lack of the type 1 interferon, which lets the virus multiply at a very high speed. And once the virus moves out into the perialveolar tissue, it produces a hyperexaggerated immune response, which is the basis for development of the ARDS. So after understanding all these pathogenetic mechanisms, we can leave the field open to Dr. Sanjay and Dr. Robert Gish to tell us how to tackle this menace. Thank you, and I'll pass on the baton to Dr. Ruvina and Dr.
Lecture on pathobiology of COVID-19. For the participants who are listening, if you have any questions, please do submit them using the chat function. The speakers will try to address as many of them as possible during the Q&A session later. Next, it gives me a great pleasure to introduce you to the next speaker, Dr. Sanjaya Satapathy. He is the Associate Professor of Medicine at the Donald and Barbara Zucker School of Medicine at the Hofstra University. He is also the Medical Director of Liver Transplantation at the North Shore University Hospital, Northwell Health. He is Editor-in-Chief for Translational Gastroenterology and Hepatology and has served as a member of the National and International Affairs Committee of the American College of Gastroenterology. He will be talking to us on GI and liver manifestation of COVID-19. The microphone is over to you, Dr. Satapathy.
Hello, good morning to my colleagues from USA, and good evening to my colleagues from Malaysia. And depending on where are you from, good morning and good evening. And also at the outset, I would like to thank the Malaysian Society of Gastroenterology and the Delhi Liver Foundation for organizing this webinar. So I have been assigned to talk about liver and GI manifestations of COVID-19. So I have no actual or potential conflict of interest in relation to this program or presentations. At the beginning, I would like to point out the summary timelines that started with a report of the first case of COVID-19 from Wuhan in Hubei province of China. And as you can see through the timeline, there has been a rapid progression of this disease across the world to the point that WHO declared a global public health emergency in January 30th, 2020. In the USA, the first case was diagnosed or reported in January 21st, and now USA tops the list in the number of cases across the world. And as you can see, there are almost close to 4 million cases that has been reported so far, and almost 187 countries have shown this. Now, COVID-19 has generated a lot of interest across the specialties. It's primarily because even if the primary site is the respiratory tract, it has a number of extra pulmonary effects, and that has generated a lot of interest among the different specialties. So gastrointestinal and liver tract is one of them, and as so many reports and so many studies have already been published in this area showing symptoms related to COVID-19, particularly with the GI manifestations and abnormal liver chemistries as well. There are other specialties that also put forward their interest, especially because there are a lot of cardiovascular abnormalities, hematology particularly an area of interest because a lot of cases of thromboembolism and pulmonary embolism has been reported. And in fact, many centers have started adopting preventive strategies to prevent pulmonary embolism and DVTs, etc. Right from the beginning, these patients are getting admitted to the hospital. So my focus is liver to begin with, and then we'll switch our gear to the GI symptoms. EASL came out with a set of questions with a consensus statement, actually. What is not clear at this time? And I try to summarize those questions and try to answer some of these questions through the literature so far published. So it remains unclear that whether the liver test alterations are a sign of a pre-existing liver disease in patients with a more severe course of infection. So that, and second, whether they rather reflect a liver damage caused by the virus itself, or whether they mirror a severe inflammatory response. As Dr. Arora pointed out, there is a hyperimmune response, and could it be a could the liver test abnormalities be related to this hyperimmune inflammatory response? And finally, the question is, does the liver injury portend to a poor prognosis? And these are some of the questions, and we'll try to answer based on the literature so far and what has not been answered as well. So the first question is whether liver test alterations are a sign of pre-existing liver disease in patients with a more severe course of infections. Now, if you look at the studies though that has been reported so far, the number of cases with a pre-existing liver disease, underlying liver disease, has not been that high actually, but the number and the percentage of patients with the liver test abnormalities are much higher. So looking at this slide, you can see the number of the studies reported prevalence of underlying liver disease from 2% to as much as 11%. So the prevalent liver disease within this community is not that high, within this population is not that high. So certainly there are more to it, is not related to underlying liver disease. If you look at the study that was published from our own center, that was the largest series of 5,700 cases by Dr. Sophia Richardson, the 58.4% of the patient has AST more than 40, and 39% has an ALT more than 60. So it does show that there is a significant proportion of these patients do present with an abnormal liver chemistries with SARS-CoV infection in the hospitalized patient particularly. Now, let us look at the study that was published, one of the earlier larger series from China, 1,099 patients. Of them, 23 patients have hepatitis B virus infections. So the question is, having underlying chronic hepatitis B virus infection, does it increase the risk of having and worse liver disease. And actually, if you look at the distribution of the severe versus non-severe disease, there is hardly any difference between these two groups. So far, there is no evidence that COVID-19 increases the risk of abnormal liver chemistry based on with a history of underlying hepatitis B virus infection. Now, the next question is, if you look at the Northwell study by Dr. Richardson, the most common comorbidities reported are hypertension in 56%, obesity in 41.7%, and diabetes in 33.8%. And similar study was reported in Cornell from New York as well, which is actually the epicenter of this the cases of COVID-19 disease. Almost a similar proportion of patients has hypertension, obesity, and diabetes. So what does it say? So it does say, so we know that NAFLD patients are at increase, have these comorbidities in common. So does NAFLD patients are at increased risk of having worse outcome based on this high prevalence of these common comorbidities? One study attempted to answer this question, coming from China, 202 patients of NAFLD, patients of with this 76 patient had NAFLD within this cohort. So what they showed that patients with NAFLD had a higher risk of disease progression, 44% versus 7%, and higher likelihood of abnormal liver function from admission to discharge, 70% versus 11%, and longer viral setting compared to patients without NAFLD. Again, this is a small study, but again, this gives us some evidence that having underlying NAFLD could modify their disease progression or presentations, and something we need to look for in more publications or more studies and to confirm these findings. Another study from China also looked into specifically looking into the liver injury, and what they have looked is from the time of the symptom onset to the presentations. If it is a longer duration of symptoms, they're more likely to have liver injury. But those who are in the hospital, they did not find much a difference, whether based on the duration of the symptoms in the hospital during the hospital stay. They didn't find much of a difference. Now, this is another study looking into the patterns of liver injury, and this is a study which is also from China, 417 patients total. And what they have shown is that they define two things. One is the liver injury and abnormal liver functions. Now, you see the liver function abnormality is quite common, almost 76% of them, but the liver injury they have reported in around 21.5%. And particularly in severe, when they looked specifically patient with a severe disease versus a non-severe disease, in the patient with severe disease, that is 46% patient have liver injury as compared to 14.4%, which is represented by the dark bars, dark solid bars, compared to patients with a non-severe disease. So it does speak that patients with a more severe illness are likely to have more liver injuries. Now, looking into the patterns of liver injury, this particular study looking at the patterns of liver injury, what they have they characterize patients into hepatocellular, cholestatic, and mixed type of liver injury. Hepatocellular they defined as AST more than 3 times or ALT more than 3 times, and the alkaline phosphatase is less than 2 times upper limit normal. They're considered as hepatocellular. Cholestatic when it is ALP more than 2 times upper limit normal, and the AST ALTs are less than 3 times. And mixed type is when both AST ALTs are more than 3 times and the alkaline phosphate is more than 2 times. So when they characterize these patients, what we can see that hepatocellular type is 20%, cholestatic was 29%, and the mixed type is 43% patients overall. But in the patients with a severe disease, which is in the middle, you can see the mixed type of presentations are more common. Now, the next question is whether liver injury rather reflect a liver damage caused by the virus itself. I think there is more speculations about it rather than actually real theories, but the speculations are based on the mechanism of viral entry into the liver cell. Now, Dr. Arora very elegantly presented how the virus entered to the cell. So as you can see, the SARS-CoV-2 has the spike protein which attached to the angiotensin converting enzyme receptor. It requires the TMPRSS2 activation by the TMPRSS2 to enter the cell. So cholangiocyte, which is in the liver, has a very high expression of AS2 receptor, 59.7% compared to hepatocytes, 2.6%. So SARS coronavirus 2 might directly bind to this AS2 positive cholangiocytes to dysregulate liver functions. So although AS2 is highly expressed in bile duct cells, but GGT was noted to be elevated in 54% of the COVID-19 patients, whereas only 1.8% patient had elevated ALP levels. So I would expect if the cholangiocyte would be the primary entry site and is causing a cytopathic effect, and maybe the ALP levels would be much higher, but which we have not seen in majority of the publications so far. So let us, I want to highlight two cases. These are case reports, and this is not the common presentations, but something may speak about a direct viral cytopathic effect. So this case was published in American Journal of Gastroenterology by my colleague, Dr. David Bernstein. This is a 59-year-old female who had a HIV infection, well controlled, and a normal liver chemistry prior to a couple of weeks ago, presented with a dark urine. There was no respiratory symptoms and presentations, and was found to have very high AST/ALT level, but no with a normal bilirubin. Her AST was 1230, her ALT was 697, but alphos was 141 only. And this patient, all the workup for alternative causes of liver disease were negative at that time, and we were wondering what is the cause of the AST/ALT. Were suspicion for, because patient didn't present with the respiratory symptoms. We're not really suspecting coronavirus, but as a routine, they started exploring because this many patients, they were coming to the hospital. They did a testing for COVID-19, and this comes out, nasopharyngeal swab came out positive. Now, this patient evolved in the next day after admission to start developing respiratory symptoms, and that actually prompted to do this COVID testing actually at that time. And then this found to be positive, and then now this patient was treated with hydroxychloroquine. At that time, was as a hospital policy, we had to treat almost every patient, even at our center. Anyway, the patients improved over the next four days and was discharged home with significant improvement in the liver enzymes at the time of the hospital discharge by day 8. Another case I would like to highlight, which just got published in Liver International, is a patient. I'm trying to highlight whether patients with underlying chronic liver disease and cirrhosis and decompensated liver disease are likely to have tipped into an acute-on-chronic liver failure if having COVID-19 infections. This is a patient with a 56-year-old woman who had a decompensated alcoholic cirrhosis, was abstinent from alcohol for about 3 months. About a month ago, had an episode of upper GI bleeding from gastric varices, who was treated with BRTO and was stable. And her bilirubin level, her liver function test right before the admission was a bilirubin 9.4, INR was 1.9, and liver enzymes were relatively mildly elevated, as expected in a patient with a chronic liver disease, cirrhosis, who had who is a decompensated liver disease. Now, this patient presented with symptoms of diarrhea, abdominal pain, and respiratory symptom, mild respiratory symptoms. Her initial workup is presented here, and what you can see that I would just like to point out the liver test in the middle panel. The bilirubin was total bilirubin in the upper panel on the right, 14.5 with a direct more than 10. Alkaline phosphate is 158, AST 741, ALT 241, and and all the inflammatory markers were much higher, and the patient had a white cell count as well. He was very minimal perihepatic ascites. Not the radiologist thought this is not even worth even putting a needle there. So he was empirically put on some antibiotics, but she was not having any significant respiratory symptoms, had a mild infiltrate in the left lower lung, and was tested for COVID and was found to be positive. and the patient did fit into the criteria of acute and chronic liver failure based on the EASL-CLIP criteria definition. So this patient was managed supportively in the hospital and improved liver enzymes over the course of a few days and was discharged. So this highlights having underlying chronic liver disease, decompensated liver disease, to be tipped up into an acute and chronic liver failure with the SARS-CoV infections. Well, this case also generated a lot of interest in our center, and we are also looking into more as a comprehensive study whether this would be a phenomenon that would be an important things to be considered down the road. There's another study we have been. This is an unpublished data, and we did a meta-analysis looking into COVID in COVID patients, severe illness versus milder illness, and we compared the liver enzymes. And what we can see, the patient with the liver enzymes are patients with severe illness are more likely to have much higher liver function test abnormalities. It's a busy slide, just the summary I would like to point out. Now, having discussed all this, what is the mechanism of liver injury? The mechanism of liver injury we can summarize based on this, that number one, this could be a direct cytopathic effect. Again, more work needs to be done, and the mechanism could be related to the ACE2 receptor entries. Second is a hyperimmune inflammatory response from the cytokine storm, and we do see routinely in all our patients admitted in hospital inflammatory markers, which includes IL-6, LDH, CRP, ferritin levels significantly elevated in this group of patients. Again, the other such thing that we need to be aware of, that patients with hypoxia, these are patients coming with respiratory symptoms, coming with hypoxia, requiring a lot of oxygenation. So hypoxia can cause hypoxic hepatitis or ischemic hepatitis in these patients, and certainly this could be another cause for the abnormal liver function test. Again, final thing that we have to keep in mind that many of these patients are also on many under different clinical trials, different drugs that could potentially cause side effects, and that could be several drug-drug interactions as well that could potentially be implicated in that liver function test abnormalities. Now, finally, one other thing that I would like to highlight, a few studies that have reported that most studies actually pointing a very high AST level, a predominant AST level compared to the ALT levels in patients with patients presenting with SARS-CoV infections. And that's something I would like to just highlight from this study that has been published in the summaries. So, in general rule that I follow so far, having said that there is no consensus guidelines yet, rightfully because there are not many studies to recommend, but this is something that I follow in my practice, and probably this will evolve with time as well as more studies will come up. But a patient with a COVID-19 with elevated liver chemistries, if we see the AST predominant elevation, AST is more than ALT, and the bilirubin is less than 5 times, and the upper limit normal and alkaline phosphate is less than 2 times, in the right setting, that is with a very hyperimmune inflammatory response, with a high ferritin, D-dimer, procalcitonin, CRP, and LDH, then you suspect it is COVID-related. And if underlying cirrhosis, then you monitor and assess for clinical course for any acute and chronic liver failure. If there is no cirrhosis, we expect a natural recovery with improvement of the COVID-19 disease itself. So the primary directions of the treatment should be COVID-19, and doing additional investigation for the liver test abnormalities probably won't be yielding any significant outcome or change in the management. However, if the patient has a very much higher ALT level compared to AST, much higher ALP levels, than more than 2 times, and bilirubin is much higher, like more than 5 times. These are patients that needs to be investigated, because I think these are patients who will may have disease that is not the liver test abnormalities that may not be related to COVID-19, and we must rule out non-COVID-19 related etiologies for these cases. Of course, this patient also needs to be monitored for ACLF as well. Now I will switch my gear because I also been assigned to talk a little bit about the GI manifestations. So having said about the liver test abnormalities, this is a study first, a very large study, 141 cases, retrospective review of patients admitted in single hospital in Wuhan over approximately 7-week period. They noted 16% patients presented with gastrointestinal symptoms only. So primary presentation was gastrointestinal symptoms in these patients. Of these 183 patients, the most common symptoms included loss of appetite, nausea, vomiting, diarrhea in 37%, abdominal pain in 25%, and AST and ALT were both mildly elevated in majority of these patients. And this is also replicated in many other studies. Again, another study from Hubei present that 48.5% had gastrointestinal symptoms. And the study, another study looking into the GI symptoms and the severity of COVID-19, 651 patients, 11.4% presented with at least one GI symptoms, that is nausea, vomiting, and diarrhea, and 10.8% had pre-existing liver disease in these patients. Again, of the patients with COVID-19 with the GI symptoms, 23% had severe or critical illness compared to 8.1%, and 31% had family clustering compared to 20% without GI symptoms. And of the patient with COVID-19 with GI symptoms, 39%, 31%, and 10% had significantly higher rates of fever, fatigue, and shortness of breath, and headache respectively. Another study from Stanford, a good colleague of mine, Dr. Izaz Ahmad, and Dr. Chalankar's group have published recently 116 patients with confirmed SARS coronavirus 2 infections. They reported 10.3% as nausea or vomiting, diarrhea in 10.3%, and a combination of the symptoms in 4.3%. 8.8% presented with abdominal pain, and the loss of appetite was 25%. Actually, the loss of appetite is a very important sign in this group of patients. And when these patients present with the respiratory symptoms, many patients, as you know, can present only with the GI symptoms as well. Especially during this crisis, we must screen these patients when the symptoms are atypical. But with the respiratory symptoms and GI symptoms, the chances of having, if a patient with respiratory symptoms is presenting with GI symptoms, there is a study I'll just show you that the chances of having COVID positive is much, much higher actually. And I would like to highlight that in a couple of slides later. I'll discuss about it. So this is a rapid review by AGA looking into all the studies that has been published so far. They pulled it out. They did a pooled prevalence estimates of the GI and liver symptoms. And as you can see, diarrhea symptoms was across all studies 7.7%. But if you look at the studies from China and you compare to the studies from countries other than China, 18% of the patients, so meaning patients presenting from outside China are more likely to have diarrhea presentations. That's how it's been reported so far. Again, across the board, nausea, vomiting is 7.8%, abdominal pain 3.6%, and these patients also have about 15% patients have AST and ALT abnormalities as well. Now, this is the study I was talking about. They looked at this is a study from New York, early clinical outcomes of patients with COVID-19 based on presence or absence of GI symptoms at the time of onset. And what is strange in this study that are unique in this study, I will say, they looked into patients' presentation of GI symptoms, presence or absence, and if the patient had an absence of GI symptoms, their likelihood of dying is much higher. So that means GI symptoms somehow is more protective in these patients, or more protracted illness maybe, but so this something tells about that GI symptoms somehow changes or the immune response in these patients. And this is the highlights of this study, the key points from that, and this will be my last slide as well. So what they found among patients meeting criteria for COVID-19 testing, those with GI symptoms were 70% more likely to be test positive. So if a patient comes with the respiratory symptoms and GI symptoms, you are more likely to be positive. That's what I was trying to highlight. And the presence of GI symptoms was also associated with longer illness duration and low rate of death during the short-term follow-up. And the presence of GI symptoms is predictive of COVID-19 positivity. And finally, these symptoms may portend a slower and a less severe disease course when they have a GI symptoms. And I think that's all I would like to say. Thank you, the organizers, and particularly Dr. Rubina Bhavani and Dr. Keong. Thank you very much. Bye-bye.
Thank you very much, Professor Satapathy. That was very interesting. Now let's move on to our final speaker, Professor Dr. Robert Gish. He is currently an adjunct professor of medicine at University of Nevada Schools of Medicine in Las Vegas and Reno. He holds numerous other positions as well, namely adjunct professor of pharmacy at Scarks School of Pharmacy and Pharmaceutical Sciences at UCSD, medical director of Hepatitis B Foundation in Pennsylvania, and medical director of Asian Pacific Health Foundation. He also has served in multiple editorial boards and has published extensively. Apart from that, he has been involved in developing public health care policies pertaining to viral hepatitis in Vietnam, Philippines, Georgia, and Armenia. Today, he will be giving his expert opinion on current treatment and future directions in COVID-19. Professor Gish, I will pass over to you now.
Thank you. Good morning and good evening. Glad to be here. Thanks for having me. I really appreciate all the education I've been getting through these conferences. Dr. Arora's given a great background. Dr. Satapathy's done a fantastic job on liver and GI manifestations. Dr. Babina, Dr. Chan, thanks for having me and hosting this conference. Sort of a pan-global event. And let's dig into therapies for COVID-19. That, of course, is the disease state, and the virus is SARS-CoV-2, which also is called the coronavirus. I have no relevant disclosures. And I'd like to highlight that this slide deck, I have a much more complete deck that's on my website. The website is robertgish.com, so you can download the larger deck there. The smaller deck also will be available for share. As you can see from this graph, the seriousness of COVID-19 in terms of causing morbidity and mortality. This is mortality rate where the COVID-19 over this 2-week period in the United States equaled the mortality rate from cardiovascular disease. This is a very, very serious issue everybody's aware of, but I'd like to highlight this graphically. You've already seen this important graph. I'd like to highlight at the bottom of this a number of the potential therapies that we're going to be going over today. I'll be focusing heavily on direct antiviral effects of some of the most developed medications that are going to be discussed, including remdesivir. I'll be touching on a variety of other therapeutic issues. I really feel strongly, and I want to highlight on this graph, that we're going to need to treat patients as early as possible to shorten infectivity, decrease the severity of disease, shorten hospitalization, decrease morbidity, decrease mortality, and I'll get into some of the logic of that. Aurora showed you this graph, and I'd like to highlight that the ideal time to treat is by doing frequent surveys of specific populations and treating people at the time of peak viremia, which is actually during the asymptomatic phase. The peak time of viral shedding is about 7 hours before patients actually become symptomatic. But we need to figure out how to be doing surveys, especially in people who have been had close contact. This is a slide that talks about the WHO effort, where they did what are performing what's called the Solidarity trial. They're still looking at hydroxychloroquine. I'll make more comments on that later. Remdesivir is part of this also. Interferon beta, interestingly, is in this global trial, and Kaletra, but I'll comment on most of these in just a moment. I'd like to highlight that SARS-CoV-2 induces a hypercoagulable state. There are a number of studies that are ongoing in terms of therapy for the more severe forms of this disease and trying to block this coagulation cascade. The D-dimer can often be in the 2000 range. Prothrombin time, which is a liver function test, can be prolonged. Platelet count may be disturbed. Fibrinogen levels may be markedly elevated. The best way to assess for the coagulation status in a patient is to use thromboelastography and then treat according to that tag pattern. You may also have a machine called ROTEM, but this in the ICU setting, cardiovascular, a transplant, liver failure, thromboelastography is the current state of the art to be assessing a coagulation state. You've already heard about this attachment process. I just want to highlight that we don't have any good data on blocking these receptors. There are hints that camostat may be involved. I also like to highlight here that H2 blockers and more importantly zinc may interfere with viral uptake. We do not have any prospective data to say the role of zinc. There was a release on H2 blockers yesterday, which I'll talk about a little bit later, that apparently abrogates disease, but it's high-dose H2 blocker only for the inpatient setting. This is an important graph because it looks, again, through the mechanism of viral entry, release, and replication, and talks about the different medications. At the very top is tocilizumab, which interferes with IL-6. Dr. Arora highlighted the very high levels of IL-6, part of the cytokine cascade and injury pattern. Also, you can see where chloroquine, hydroxychloroquine act, although they really act at probably 5 or 6 different steps. I'll make specific comments on those shortly. Lopinavir has also been studied but has failed. I'm going to take that off the table as a potential therapy. Ribavirin is being looked at as well. Favipiravir, which is at the bottom, just had a publication in Lancet showing decreased viral shedding, a shortened period of viral shedding, and we'll wait for further data on that medication in terms of changing patient outcomes. We're starting to see clinical data on favipiravir. A little bit more on ACE inhibitors and ARBs. There was a concern that these might in some way enhance risk of death and morbidity from this disease, but it looks like they may lead to a lower death risk. So the standard of care is to continue these medications unless the patient is hypotensive, not specifically stopping them to try to abrogate the disease, but we would not be recommending starting ACE or ARB inhibitors to try to modify the disease state in someone who doesn't have a clinical indication for these antihypertensives. This is just a publication of the failure of lopinavir, ritonavir. The theory was lopinavir with ritonavir boosting may have an antiviral effect, and there's some mechanistic discussions about the theory behind this, but this is a failure. I believe we need to set this aside. Okay, let's talk about tocilizumab a little bit more. We have some small studies or case series. This is one study with 21 patients treating according to protocol. Unfortunately, the patients were also on lopinavir, methylprednisolone, making it a little bit more difficult to interpret the study results, but there was suggestions here in the lower left box about a shortened time requiring intensive oxygen support, and in that same graph about improving oxygenation. So this is for hospitalized patients, patients with declining oxygen delivery. As you know, there's a very strange disconnect between hypoxemia and tachypnea. There's something that has changed with the SARS-CoV-2 and how the brain receives oxygen and carbon dioxide signaling. So best way to pick up hypoxemia is through an oxygen sensor. It's an early way to detect pulmonary involvement. A little bit more on chloroquine and hydroxychloroquine, blocking cytokine expression, changing lysosome pH, as you heard from Dr. Arora. Through this, there was strong theories that this was going to work, but as you know, the data has emerged that there's minimal clinical benefit and increased risk of morbidity and mortality. There was the VA study that showed a 2.6 increase in mortality rate. Strongly advised by the FDA and other experts that this should only be studied in prospective controlled trials in a hospital in a monitored setting. This is one of the studies that talked about risk of fatal heart complications, a study from Brazil, but there's been multiple other studies, including the VA study that I mentioned. This is a high dose group of with a odds ratio of 3.6 increasing complications. This was adjusted for age, for chloroquine dose, and there was a 60% mortality in 5 patients with cardiac disease. So really what I'd like to highlight here is that SARS-CoV-2 has a major effect on cardiac function, cardiac inflammation. Hypercoagulable state is also probably causing cardiac damage. Close monitoring of QT interval, having a baseline QT and monitoring during therapy. It's currently advised that this hydroxychloroquine should not be combined with azithromycin. There was some hint that there is decreased RNA production or shedding, but there was no specific clinical benefit. This is the study about high-dose famotidine. Famotidine does appear to modify clinical outcomes in one study that was published yesterday. I haven't seen all of the details yet. It does have a protease effect that may be inhibited, that may inhibit viral replications, but we're going to need more detail. High-dose famotidine does also have cardiac effects, and you need a dose reduction if there's renal dysfunction because of renal clearance. So more to come on H2 blockers. Again, only should be looked at in randomized controlled trials. This goes back to anticoagulation. This is just a case report of combining IVIG with potentially neutralizing antibodies with low molecular weight heparin associated with clinical recovery. This, I'd like to highlight here, has to do with the complexity of many of the studies that we are going to be looking at. And patients are often treated with 1, 2, 3, or 4, either antiviral, anti-inflammatory modalities, or both. So we're going to be really needing a substantial, good, well-designed clinical trials to be able to sort out what's going to have the best clinical benefit for our patients. Convalescent plasma is being looked at. I'd like to highlight that this is operationally a difficult issue. You've got to identify your patients. You have to find high titer antibodies. You have to bring those patients in for phlebotomy and then plasma concentration, and then distribute this. It's quite expensive. There was some data from the SARS, MERS, and the 2009 H1N1 influenza epidemics. There was a meta-analysis of 32 studies, and it looked like there was a reduction in mortality rate, but this is going to need to be looked at specifically in SARS-CoV-2 to decide about the role and whether this is worth the expense. A little bit more look about convalescent plasma. The left is 10 patients, the right study 5 critically ill patients on both of these studies hinting at some clinical benefit. If you look at the bottom bullet in both of these 2 columns, though, you can see each patient was on a variety of other medications at this time. And the question is sorting out what's the benefit component of the convalescent plasma for these patients. As you know, we clearly have, at this point, have not identified what antibodies are viral neutralizing. We know that there's an early IgM response that's transient that may last 4 to 5 days. There's an IgG response that is less evanescent. It can last for weeks to months. Which of those antibodies are neutralizing is a big question. I'd like to highlight here that IgA is probably very important in protecting our bodies from the coronavirus and also abrogating disease. And we'll be talking more about IgA in the future, both in terms of testing and a potential role in therapy for our patients. This just gives you information about these patients all demonstrating improvement in clinical parameters. 50% of mechanically ventilated patients were extubated. At the time of this study, if a patient was mechanically ventilated, data was being published as that the mortality rate was 50 to 80%. There were improvement in inflammatory parameters as well. As you heard from Dr. Aurora, there's a number of different laboratory tests that you can use to assess severity of disease and to monitor the inflammatory process that are relatively simple that can be performed at most labs. Let's switch now to the RNA-dependent RNA polymerase inhibitors. I mentioned there's a publication that was just released by in Lancet on favipiravir that did support that there was decreased viral shedding in these patients, but I didn't see clear data on a clinical benefit, but we're going to need larger trials. The adverse event profile was quite low. We're going to spend more time on remdesivir today. Remdesivir was originally developed by Gilead Sciences to combat Ebola. Apparently that was either ineffectual or the studies weren't powered to show a benefit, but they did have data dating back 6 or 7 years about the efficacy of this drug against different coronaviruses, including plans to look at SARS and MERS clinically. but these disease states fortunately were rapidly halted due to a variety of different interventions and probably some viral characteristics. But let's dig into remdesivir as a treatment for the coronavirus, SARS-CoV-2. This is the first study that came out in New England Journal of Medicine. I'm not going to go into great detail here, but you can basically look at these baseline oxygen support and looking at the curve of clinical improvement. This is using the WHO 6-point ordinal scale, and then on the right graph looking at the differences in improvement time depending on age, with slower improvement in older patients. But nonetheless, the majority of these patients had some type of invasive oxygen support, and there was marked improvement graphically, clinically, and a marked decrease in the number of patients who required intubation over time and a low mortality rate. So even though it was a case series, this did provide encouraging results that led to the continuation of multiple other studies, which we'll talk about. This is the simple study. This is going to be looked at also not just for clinical benefit. Again, the 7-point scale that's by WHO. I said 6-point before, but it's a 7-point scale including 0, and looking at time at day 14 and trying to look at, was there a difference between 5 and 10 days? So looking at clinical benefit and looking at duration of therapy. There was, from this study, the 10-day and 5-day course looks similar. So that's going to help with further planning and clinical management of our patients. Time to clinical improvement for 50% of patients was 10 days in the 5-day treatment groups. That gives you a good timeline for clinical recovery. Clinical recovery was achieved in 64% of patients at day 14. This is a very, very clinically a substantial level of patients. And patients received remdesivir within 10 days of symptom onset had improved outcomes compared to those who received treatment later. So the earlier the institution of therapy, just similar to what we see with influenza A and Tamiflu, is that the earlier you take it, the shorter the disease state and clinical symptoms and signs. So I think we've covered all the issues on here. More than half of the patients in both treatment groups were discharged from the hospital by day 14. Let's look at the NIH study. Oh, sorry, I don't know why that went forward. Let's go back one. This is the NIH study that was just published also this last week about accelerating recovery. This got a huge amount of press attention, including information from Dr. Fauci, the head of the NIH. I would like to remind everybody that yesterday, Dr. Fauci had to go into self-quarantine, as did Dr. Hahn, the head of the FDA, as did Dr. Redfield, the head of the CDC. So 3 of our top people in the United States are all in self-quarantine because of coronavirus exposure. We're expecting to have a number of other people in the upper levels of the US government in self-quarantine in the near term. At least that's my prediction. There's been a lack of social distancing, a lack of mask wearing by our wonderful leaders, and unfortunately there's now a price that's being paid for those individuals. Let's get back to the trial. I apologize for the editorial comment there. The primary endpoint was time to recovery. That was shortened from 15 to 11 days in this study with a p-value of less than 0.001. Mortality did not reach statistical significance, but there was a trend of 0.059 from 11.6 to 8%. So I think there's some very important information here. This has led to Gilead releasing remdesivir globally. Every drug that can be produced is going to be distributed, and there's going to be distribution in the US through the US government and distribution throughout the world through other intermediaries. So this is one of our first true encouraging treatments because of 3 properly designed studies that will give us a signal on how to use this to manage our patients. So we had an independent data monitoring board who oversaw this trial, which is very important as well. Many of the chloroquine and hydroxychloroquine anecdotes that took place were not monitored in a prospective controlled fashion. They were specifically case reports. And we have the NIH also making a statement that suggests a survival benefit for this. We have another 7 major studies ongoing with remdesivir globally. We're going to have a lot more information here in the near term. I'm not going to read through all of these lines from the IDSA, but I would encourage you to look at the IDSA document. This is a living document strongly recommending hydroxychloroquine and chloroquine only be used in the setting of clinical trials. And there is very major caution about the use with erythromycin. I'm going to make a statement the lopinavir and ritonavir study should be halted. I do not see a role for those, although there was another press release this week about using lopinavir and a comment about Atripla, one of the lead drugs for HIV management that may abrogate coronavirus. But let's not move quickly on these until we have larger studies and controlled studies. Steroids only for patients who are extremely ill in the ICU who fit steroid treatment criteria. There is at least one reasonably good study that suggests that steroid broad-based use in severe coronavirus patients makes patients worse. I can make a comment about transplant patients here and immunosuppressed patients also who may have a variety of different autoimmune diseases. There is no reason to decrease their immune suppression in patients with mild coronavirus infections. In more severe infections, most centers are slowly reducing immunosuppression, and the more severe the clinical manifestation of SARS-CoV-2 or COVID-19, the more significant the reduction in immune suppression. But we don't have any controlled studies to guide us specifically there. This has basically just been common sense, but let's be cautious about the use of immunosuppressants. I've already made some comments about tocilizumab, and I think we've wrapped that up as well. Are there any other comments on here? I think we've covered all these points inside my presentation. In transplant patients, I think there's a question that came up about surveying liver transplant or solid organ transplant patients, or immune suppressed patients for that matter, routinely for the coronavirus. I would say that needs to be done only in appropriate clinical settings. Just random surveys of transplant patients by PCR, I don't think has a specific clinical role. You saw this graph or diagram from Dr. Aurora about vaccination. I want to bring up the vaccine issue here, and that this is a difficult virus to provide vaccination for. RNA viruses in general have been difficult. There's been a history, case of dengue, to develop a vaccine where the vaccine actually made the patients who were exposed to dengue and were infected worse. There's an inflammatory response that these vaccines can bring about that can cause more severe disease, or more severe or hyperimmune response. So we must be very cautious. The coronavirus activity now is about 30 vaccines in clinical trials, about 6 in humans, and a combination trial may be ready. Some people are putting out press releases that we may have vaccines by September. What that means is we may have vaccines in phase 2 or phase 3 trials by September. But being realistic, it's going to be 2021 before we have vaccines that are going to be available for clinical use globally. That's at least my current opinion. Pharma needs to be working together in collaborative fashion. President George Bush a few days ago talked about collaboration during this pandemic, that we need to be working as a team. We need to get rid of all the partisan issues that are ongoing. And of course, our wonderful President Trump came back with an attack against President Bush for his advocacy for collaboration. We really do need teamwork globally. We need WHO involvement. We need support for our global institutions and global interactions. This is the favipiravir, and I'd point you to an article published in Lancet this week. A little bit more on another cytokine medication that's being developed. This is what's called the Odyssey trial. It's using neurokinin-1 receptor antagonists, another inflammatory pathway that may abrogate the ARDS and pulmonary inflammatory process of SARS-CoV-2. Wrapping things up now, this is giving you a research pipeline: vaccines, antibodies, antivirals, entry inhibitors, cell-based therapy, including stem cells, RNA-based targets also are being looked at, and there's a lot of global scanning compounds to repurpose medications that are currently available, looking at medications such as nitazoxanide, which has been around, of course, for decades, and has been looked at for other viral infections, including hepatitis B and hepatitis C. I want to thank again the organizers, INEDSYS, for putting this together, Dr. Anil Arora, Dr. Satapathy, for your brilliance in bringing our globe together, Dr. Babina, Dr. Chan, for your support, and Malaysia and all the other participants throughout the world. Be safe, everybody. Social distancing, follow the strict guidelines by WHO, CDC. Don't listen to the fake news out there that we're going to bend the curve any other way. Thank you.
Excellent talk. So now we have some questions in. Let's begin with questions directed to Professor Arora. Professor Arora, can we have you with us? All right. So I have two questions for you. The first one is, does the different strains of COVID-19 have an impact on the clinical manifestation?
So far, in different countries, there are three important factors which lead to differences in the mortality. If you look at the tropical country like ours, which has constraints of the resources, our mortality is anywhere from 2.5 to 3%. And there is one study published from Genetic Institute in Hyderabad, which has already isolated 7 strains, which are different from the strains which have been reported from the US. So the temperate climate, humidity, and genetic strain all do contribute to the way the body will respond in terms of the immune response. So possibly the immune response which is generated in our patient with our type of strain, coupled with tropical temperature which we have, certainly leads to lesser mortality as compared to the colder climate.
All right. And the second question is there any genetic correlation between COVID infection
as of
and
now,
death?
there is no documented proof in COVID-2. But if you see the coronaviruses in the past, so unless it is presumed that some of the genetic polymorphism, especially the IL-6 polymorphism, has been implicated in exaggerated immune response in SARS-CoV infection and MERS. There is no study which has been documented in a similar fashion in the COVID-19. But if you can extrapolate the data, then the polymorphism of the enzyme, especially the IL-6 polymorphism, I've shown you one slide how IL-6 which basically tries to decrease the apoptosis of the cells, decreases the acquired immunity, which decreases the apoptosis as well as the cytolysis of the cells. So if you have a polymorphism, it has been documented to be of relevance, not in the COVID-19, but already in the SARS-CoV-1 infection.
I will now pass the mic to Dr. Chan to continue with the Q&A session.
Thanks, Rubina. So can I have Dr. Satapathy on, please? I've collated 3 questions for you. Dr. Satapathy, are you first?
Yes. Yes.
So the first question is whether higher serum aminotransferase level is predictive of more severe COVID-19.
So, so far, the answer is not clear. However, what has been, we actually have presented unpublished data, this is a meta-analysis looking into all these studies been published from China that we did. And what we have shown is that patients with more severe illness are more likely to have much higher level of AST and ALT and bilirubin abnormalities, they're much higher level. So to extrapolate that information, I will say probably with the patients who are much sicker are more likely to have higher liver test abnormalities. And how we can correlate this, and we probably, this is because of the bystander effect, because these are more severe, sicker patients, meaning much more higher inflammatory response. And those hyperinflammatory response probably causes a bystander effect in their liver. Question is whether it is a direct cytopathic effect. I don't think we can only speculate that part of it, but I believe it is all related to the cytokine response. And preliminary data from our center, which is I was working on it. I do not want to reveal the results yet, but I do think there is a clear relationship with this high inflammatory response and the liver test abnormalities.
So in case there's a COVID-19 patient who is hospitalized and the serum aminotransferase level is found to be high, but the patient has not become worse yet, would that actually guide you in predicting that this person may actually have more severe disease eventually?
We don't know the answer to that question yet. Okay. However, my observations from clinical observation, I will say most of these patients, they improve once the respiratory symptoms improve. So the clinical course is not determined probably by the liver test abnormalities, but is determined more by the respiratory symptoms.
Thank you. The second question is regarding patients with cirrhosis who had an episode of varicose bleeding and already has endoscopic varicose ligation. So, subsequent management of this patient, would you still bring this patient back for obliteration of the varices, or would you optimize the beta blocker?
So this is the patient with a SARS infection. So we're talking about the patient already has a COVID infection, you said?
No, the question did not specify whether this patient has COVID-19, but
okay.
It means in general, if you have a patient
in general, in this time period. Okay.
During this pandemic.
Yeah. So in general, when the crisis is ongoing and the hospitals are, the physicians are so occupied, and in fact, in our center, where we are the epicenter of the epicenter, I will say, our physicians are redeployed to take care of the coronavirus patients. So we are prioritizing patients who necessarily need an endoscopic intervention. So in fact, pretty much we are scoping patients who actually have an upper GI bleeding and managing those patients in hospital. Elective endoscopies, we've been pushing it for now as much as practically and reasonably we think assessing the risk and benefits, we're trying to push them beyond certain period of time. So a patient, of course, has come with a varicose bleeding within 4 weeks' time, and we want to bring them. In usual practice, I bring them in 4 to 6 weeks' time. So I may actually push them to 2 months to 3 months. I don't think that's going to change significantly their clinical course. I would put them in beta blocker and continue follow up that way.
Thank you for a very clear answer and very useful advice. So the last question I have from the participant would be your comment on management of a post-transplant patient who is COVID-19 positive. I suppose.
Yes. So yes, I think it's very important. Yeah, the COVID patients, post-transplant patient with COVID-19 infection, if they're asymptomatic, we still keep them at home. We do not change the immunosuppression. There is not advised to change. If they're symptomatic patients and they're hospitalized, yes, we do bring them to the hospital and we reduce their immunosuppression, especially CellCept, mycophenolate mofetil. That's one we discontinue them. And the other immunosuppression will reduce by around half, depending on how far they are out from their transplant period. If they're very shorter interval, of course, try to keep it as minimal possible of the immunosuppression of those patients. And there is also this the studies that came from Italy that has shown that the patients with patients who are post-transplant immunosuppressed patients are having a worse outcome. So those are things that I would take into account and reduce their immunosuppression at this point.
Okay, thank you very much, Dr. Satapathy, for the very insightful talk and answers. I will just pass the microphone back to Dr. Ruvina. I think she has collated some questions for.
Hi, Professor Gish. I think most of the questions have been answered through the chat box by all the speakers. But I think, would you like to just summarize? Because I think one of the popular questions for you would be, does hepatitis C drugs have any potential role in treatment of COVID?
It's a fantastic question, and there is in vitro data for the hepatitis C drug sofosbuvir specifically, and also interestingly, the hepatitis B family of drugs that are TDF or tenofovir based, that there's an effect on SARS-CoV-2 in vitro. And I think there are plans to be looking at these medications in human trials. It's also interesting that lambda interferon, which has been studied for delta hepatitis, hepatitis B, and hepatitis C, also in animal studies, has a profound effect on viral replication. There are at least 6 international trials ongoing with lambda interferon today. I didn't bring that up, but this is an opportunity from the viral world, the viral hepatitis world.
Thank you, Professor Gish. I think in view of time constraint, me and Professor Chan would like to wrap up the session.
Okay, so on behalf of the Malaysian Society of Gastroenterology and Hepatology, I would really like to thank Professor Anil Arora, Professor Sanjaya Satapathy, Professor Robert Gish, as well as the team from INEDSYS for making this webinar possible. I would also like to thank all the participants for their active participation. We certainly look forward to more such interactions in the near future. At the meantime, please take care and stay safe and healthy. Have a wonderful day and see you again soon. Thank you very much.
Thanks, everybody.
Thank you, everybody. It was a pleasure meeting you all. Hope to see you again. Thank you so much.